Do you see the screen, my screen?
Yes, we do.
Yes, okay. So welcome everybody. Goedemorgen, good morning, bonjour. It's my pleasure to introduce to you the story of clinical and medical genetics in the Democratic Republic of Congo. And well, for those who do not know where the DRC is, if you look at Google Maps, the DRC is really the center of the world. Yeah. And here, this arrow indicates where Kinshasa is the capital of the Democratic Republic of Congo, where most of the activities of the center are taking place. And here, far up north, this is Belgium, Leuven, and the Center for Human Genetics in Leuven. So about 14 years ago, by now, staff members from the Leuven Center for Human Genetics started to have regular missions to Kinshasa, and they were mainly driven by Professor Prosper Lukusa, who is a former collaborator in Leuven, who went back to his native country, and we accompanied him. So we engaged in teaching, education, both in the bachelor's in medicine, but also the postgraduate, mostly in pediatrics. We organized genetic clinics. And actually the aim was to get insight in the local situation. And our ultimate aim was to try and contribute to building a center for human genetics locally in Kinshasa that meets the real needs of the African population. And this by taking into account the local medical, but also social, ethical, and legal aspects into account. So we met academics, we met clinicians, so doctors, we met patients, we met researchers, but we also met policymakers locally. And this really gave us insight in how to reach this goal. But I will now give the word to Professor Lukusa, who is currently the head of the Center for Human Genetics in Kinshasa. And I think he's best placed to explain how this went along.
It's my great pleasure to welcome you to this virtual talk of the Center for Human Genetics at the University of Kinshasa, Democratic Republic of Congo. The DRC is one of the largest countries of Africa, located really centrally in this continent. The population is estimated at more than 90 million. With a very young population, 16% inheritance, less than 20 years, you can understand why more than 1,700,000 babies are born every year. For comparison, in Flanders, annually 60 to 70,000 babies are born. We all know the achievements of medical genetics in the last decennia in the world. There is not a single specialty in medicine where genetics is not involved anymore. Also, in DRC, patients and families are confronted with hereditary diseases and they need genetic expertise in the same way. However, until recently, no doctors were trained in clinical genetics. There were no clinical genetic services. Genetic tests were hardly available, and research in this domain was lacking. This had to change. We therefore dreamed of a center of excellence in the field of human and medical genetics in Kinshasa. The mission of this center was to provide service to the population, to perform research on genetics and domains that are a priority to the populations, and to offer teaching and education to health professionals in the GMC. In this, I have the example of the Center for Human Genetics in Leuven, Nantes. I was deep trained there, and I obtained my PhD in genetics there. Moreover, during the 1960s and 1970s, Professor Herman van den Berg, founder of the Leuven Center for Human Genetics, also created a genetics center at the University of Leuven in Kinshasa. This is the Center for Human Genetics nowadays. The team consists of 10 medical doctors, of which 4 have earned their PhD in the field of genetics, while 6 others are PhD students and 1 lab technician. We also have 1 bioinformatician and 1 secretary. Thus, there is time for team development. Since our first steps, we also urgently worked through the establishment of Congolese Society for Human Genetics, which held its first successful congress in Kinshasa in May 2013, and the second one in Lubumbashi in May 2015. This initiative was supported in part by the VLIR-UOS. The Congolese Society for Human Genetics presents the genetic community from the DRC and coordinates various national initiatives. It also fulfills a liaison role with the international community of genetics.
So you've heard that the mission of the Center for Human Genetics is actually threefold. One is the provision of clinical genetic services to the population, both clinics and laboratory diagnosis, education and training of medical personnel, but also providing information to the population and policymakers and research. And obviously, these 3 are interconnected. So the goal was to build capacity in these domains. And obviously for this, we also needed infrastructure, especially for the laboratory diagnosis aspect and research. So how to handle this? Well, our vision was to initiate research projects, because this would allow us to build capacity, to gain knowledge, and at the same time build infrastructure. And you all know you need a lot of money for this. And well, grants are not very easy to obtain, but we were all very determined. And I would like to specifically thank all our sponsors and organizations who funded our research in these past 10 years. Without this, this would not have been possible. I will now give the word to Professor Lumaka, one of the collaborators of the center, and he will explain to you the challenges of trying to build a genetics laboratory in Central Africa.
Hello, everyone. A genetic laboratory in any modern city has to meet a number of requirements to earn the trust. It is known as quality assurance system. The minimum standard included management organization, research documents, continued improvement and training, a clear flow of testing and reporting external service that includes reference system and making also the system affordable for the community it is offered to. When it comes to Africa, those infrastructure are not available. We need to start really from scratch. In our case, we received a room like this one where there was nothing available to make it a laboratory. We needed to work it out from really scratch to install electricity, to install water supply, and have a freezing system because the room temperature or the environmental temperature is really high, which is not good for storing of reagents. And this is the final result we obtained. We were able to set up a laboratory that met minimum quality requirement for in terms of a room or accommodation. On the other side, there is also a struggle for equipment. Heavy equipment that you can find in a genetic laboratory in Belgium are not available for us, or they are not affordable. We were lucky with the collaboration and different projects we have developed with the VLIR-UOS to get some equipment that you can see here, the mini cab that allows us to do sickle cell anemia testing. My colleagues are going to dive deeper in the presentation that are coming next. We have been able to acquire from our proper funding a sequencing, benchtop sequencing machine, a new PCR machine, but they also, without the support from the government, we don't have the clearance for the custom to make those equipment deliver in a country. So these are still staying in the supplier for the moment because of the lack of the clearance from the custom. There is a trouble we are having, or we were having, for reagents supply, because there is a limited number of suppliers on the field and the prices are really expensive. So what we have done is to purchase from Belgium raw material that we can condition ourselves when it's possible so that we could have good quality reagent to be used. Training is an important part. Thanks to the collaboration with the K11, all but one of the people you can see on this photo have all been trained or are being trained partly or fully at the K11, which ensure that we have a well-trained team of people that can provide a good laboratory service. And contemporary genetics testing in Europe rely on heavy sequencing machine. The whole genome of an individual is sequenced and interpretation is done using heavy computing capacities that are not available in Africa. Instead, we have opted to start with the interpretation part, which require less heavy bioinformatic equipment, and we are also trying to provide type of testing that are needed by our community, including tests for sickle cell anemia that is going to be presented. I am going to finish my presentation with this report made by the national TV that is capturing the whole collaboration we are having with the K11 and the VLIR-UOS, and it's present a moment where a bulk of equipment was received from the K11. Thank you very much.
Possible avec l'acquisition des matériels de laboratoire de génétique humaine que vient de bénéficier la faculté de médecine sont là à l'Université de Kinshasa, matériel provenant de la Belgique. Reportage Patricia rendu par Patrick Condon. C'est dans l'université élèves de la Belgique par lesquels les professeurs de Prosper étaient composés de les professeurs Jean-Marie Caïné, ces matériels sont destinés pour les centres de génétique humaine de l'Université de Kinshasa dans le but de renforcer sa capacité de recherche des ADN et autres.
So the idea of starting with research to build capacity and an infrastructure, then we obviously needed to define good research teams. And well, obviously they need to be relevant for the Congolese population, and questions that can only be answered by research locally in the community. And as for all research, it has to be in line with expertise, but also interests of the Kinshasa and Leuven teams and other collaborators. And at the onset, we defined 3 large teams. The first one is sickle cell anemia, which is a hereditary disease of the red blood cells, then oculocutaneous albinism and developmental disorders. And in what follows, it will become clear why these are important and what steps have been taken since. So we were very happy to be able to recruit young and very enthusiastic PhD students for these different projects. So let's start with sickle cell anemia. Most genetic disorders are found anywhere in the world, but sickle cell anemia is a notorious exception. As you can see here, it's most prevalent in Central Africa or Africa below the Sahara. Yeah, and really in the DRC, the incidence is very high. About 1 in 70 newborns is affected with this disease, which means about 40,000 newborns annually in the Democratic Republic of Congo. And the drama is that almost half of these children die before they reach the age of 5 years. So clearly, this shows that this disease is a very high priority for the population. And I think over 5 years ago, we obtained funding, a team project from VLIR-UOS, to initiate a research project, both regarding diagnosis and treatment of patients with sickle cell anemia in the Democratic Republic of Congo. And these are the participants, and each of them will explain his part, her part in this project. And first, the word is to Professor Tite Nikobi.
I'm Tite Nikobi. I'm one of the collaborators of Professor Lokusa, the head of the Human Genetic Laboratory. In my role within the laboratory, I deal in general hemoglobinopathies and in particular sickle cell anemia. In this field, our laboratory is the only one in Kinshasa and even in our country which carries out the molecular analysis of sickle cell anemia. In recent months, we have just implemented the antenatal diagnosis of sickle cell anemia by amniocentesis. Dr. Mani Gode, one of our students from our laboratory, will be present the technology we use. In addition of the molecular tests for sickle cell anemia, our laboratory is also equipped with a capillary electrophoresis device thanks to finding for pain. This device always biological monitoring of sickle cell patients who are under treatment for hydroxyurea. In effect, hydroxyurea is the only medical treatment currently that has improved the quality of life of sickle cell patients around the world. This device makes it possible to quantify the fetal hemoglobin to access the response to treatment, because one of the effects of hydroxyurea is the synthesis of fetal hemoglobin. Currently, hemoglobin fetal is one of 2 genetic factors that modulate the
the sickle cell anemia phenotypes. We can now visit our laboratory with the different members with the respective field of research.
So now Dr. Mamie Ngole, she's a clinical biologist, and she got the task to actually introduce genetic testing for sickle cell anemia in the laboratory. The sound is rather poor, so that's why we have subtitles. Okay, now I will switch to the second part. So besides this laboratory aspect, do you see this screen?
No, Professor, we don't see it.
No. Okay, let me try again. Yeah, now you should be able to see it. Okay, so obviously taking care of patients not only implies reaching a reliable diagnosis, as Dr. Ngoli explained us, but also we tried to treat patients with hydroxyurea, the only treatment available today. So we have two clinical trials, one in Kinshasa for adult patients, this is by Paul Lumbala, and then another one for children in Kisantu, which is a hospital located about 120 kilometers away from Kinshasa. And this is by VLIR-UOS. So let's first hear the experience of Dr. VLIR-UOS in Kisantu.
My name is VLIR-UOS. I'm a pediatrician. So we conducted a study about the diagnosis and treatment by hydroxyurea of children with sickle cell anemia in the Democratic Republic of Congo. The sickle cell anemia is the most genetic disease in the world. And in the Democratic Republic of Congo, the prevalence of this disease is very high. So the prevalence of the homozygous form of sickle cell anemia varies between 1 to 2%, and the prevalence of heterozygous form is around 20%. The sickle cell anemia causes anemia, painful crisis, and susceptibility to infection. That study was conducted in Kinshasa Hospital and funded by VLIR-UOS. We chose Kinshasa Hospital because it's a rural hospital located 120 kilometers away from Kinshasa. Also, Kinshasa Hospital has a partnership, a long partnership with the University of Kinshasa, University of Leuven, and University Clinic of Leuven. So, we recruited 160 patients or children following in Kinshasa Hospital for sickle cell anemia. That patient was detected, was confirmed, was diagnosed using an email test. But among all the patients, after DNA testing, only 136 patients was confirmed to have sickle cell anemia because DNA testing is the gold standard. It's not effective by the young age or the recent transfusion. And among all the patients, all the sickle cell confirmed patients, we give hydroxyurea to the patient severely affected. To know that patient is severely affected, he has to have in the previous year at least 3 painful crises, 3 hospitalization, and 3 transfusion, and the low rate of fetal hemoglobin. And after giving hydroxyurea during 2 years, we observe the improvement of clinical feature, of clinical profile. In fact, after 2 years of treatment with hydroxyurea, we observe the decrease of the number of painful crises, the decrease of the number of transfusion, the decrease of hospitalization. And we observe also the improvement of the increase of fetal hemoglobin. So we can say that DNA, that project funded by VLIR-UOS, allow us to know that, to confirm that DNA testing is the gold standard, and also hydroxyurea is important to improve the survival of sickle cell anemia children.
So that was the experience in Kisantu in children. Now we will hear Dr. Paul Lumbala, who was actually following adult patients and his view as a pediatric cardiologist.
Hi, I'm Paul Lumbala, a cardiologist. I am member of the team of genetic department of the University of Kinshasa. My work is focused on sickle cell anemia, a disease which is very common in the Democratic Republic of Congo, where the mortality is high, with the most vulnerable period being under 5 years old. This situation is now changing slowly with the improvement of socioeconomic condition, early diagnosis, and improvement of care focused on effective treatment of anemia and infection. We can then observe an increase in life expectancy in sickle cell anemia patients. However, the observed increase in life expectancy in these patients is accompanied by the increased frequency of chronic complication of sickle cell anemia, especially chronic organ damage concerning the cardiovascular system and the kidney. This organ damage is an additional vital threat for the sickle cell anemia patients. In fact, cardiovascular complications are represented by an enlargement of the left ventricle, the alteration of its pump function, and the onset of pulmonary hypertension. Thanks to the funding by VLIR-UOS, we got the opportunity to conduct a trial with hydroxyurea, an effective treatment for sickle cell anemia approved by the FDA in the US and most of rich countries in the world. We took this opportunity to study determinant of the response to treatment with hydroxyurea in our patients. And we also study whether treatment with hydroxyurea will slow down the heart disease. Follow-up of our patients included a monthly visit for a clinical examination and follow-up of biological parameters in selected patients. At the time of this visit, patients are also refilled in medication, hydroxyurea, and we look for any side effect of this treatment. Also, the dosage of the medication are adjusted according to the patient's weight. The cardiac ultrasound was performed every 3 months for the evaluation of morphological and functional change. The evaluation of the pulmonary vascular hypertension was made through the evaluation of the tricuspid regurgitation jet velocity. When this velocity was as high or more than 2.5 meters per second, this patient was considered as at risk of presenting a pulmonary hypertension. And in the follow-up, the data, the echographic data, the initial echographic data will be compared with the final data to see if there is an improvement or a worsening of these parameters in each patient. At the end of this trial, we will be able to identify genetic factors that determine the outcome of patients in our region. Thank you for your attention.
So, as you heard, thanks to the very hard work of these talented young physicians, we gained a lot of experience on sickle cell anemia in Kinshasa and in Kisantu. They are currently collecting their data, analyzing the data. Manuscripts are being written, and I'm very confident that in the course of next years, the 3 of them will be able to defend their PhD thesis in Leuven. But let's now move to a second condition, oculocutaneous albinism. And again, for reasons which are not fully understood, this condition is very prevalent in sub-Saharan Africa, in contrast to most other parts of the world. And albinism means lack of pigment. And we have black pigment in our eyes. So having no pigment means that you have visual problems. Absence of pigment in the skin gives you a skin without color. And in an African situation with the very hot climate, the very sunny climate, you can imagine that they are exposed to skin complications, and especially cancer, which may occur already at a very young age and is life-threatening. However, a very peculiar aspect of oculocutaneous albinism in Central Africa is that these people really have to fight during their entire life for discrimination. Professor Leticia Mavinga, whom you can see here, is a very talented clinician and researcher. She's a pediatrician, and she set out to study genetic and clinical aspects of oculocutaneous albinism in Kinshasa. And actually, last month, she defended in Kinshasa her PhD thesis. But as you can imagine, that performing research with people with oculocutaneous albinism is not so easy. You really have to gain trust of this community. And I think Professor Leticia, she really succeeded in a wonderful way, because she put the care for people and their families with albinism central. She had a very close interaction with the patient organizations, and she has a continued engagement towards these patients. And as a proof of this continued engagement, she is now one of the main participants in a VLIR-UOS joint project. It's a network for research and multidisciplinary medical care for people with oculocutaneous albinism in the DRC. And actually what we try to do there is to bring together expertise from the three main cities in the DRC, Kinshasa, Kisangani, and Lubumbashi, bring together the expertise to actually improve medical care for those people. And in addition, this will lay the foundations for further research. So last week, this joint project held a meeting in Kinshasa, which was picked up by the local television, as you can see here.
Victimes des discriminations à travers le monde, les albinos sont des personnes à part entière qui méritent l'attention et la considération de tous. L'albinisme, une maladie héréditaire, rare et non transmissible, existe dans le monde entier, indépendamment du genre et de son appartenance ethnique. Il est aujourd'hui possible en République démocratique du Congo de se faire dépister avant le mariage pour prévenir la naissance d'un albinos dont le couple a soutenu le professeur Dr Leticia Mavinga. Cette matinée scientifique de sensibilisation sur l'albinisme du 15 juin aux cliniques universitaires de Kinshasa a été riche en exposés des pédiatres, ophtalmologues et dermatologues autour du thème « Mieux connaître l'albinisme en RDC ». La présence du ministre des Personnes vivant avec handicap, Madame Irène Essambo, à cette journée scientifique, prouve à suffisance, selon elle, son souci de valoriser cette catégorie de personnes. En sa qualité de chef de service de génétique au département des sciences de base, le professeur Dr Lukusa Prosper est revenu sur la quintessence de cette journée de sensibilisation.
La journée d'ici aujourd'hui, c'est surtout approfondir les aspects scientifiques qui ne sont pas approfondis dans les forums ordinaires qu'on organise sur l'albinisme.
Le président des associations des albinos du Congo a eu le mot juste pour remercier le responsable du département de génétique humaine de la faculté de médecine qui ont vu juste en organisant cette journée qui vise à sensibiliser et à revaloriser la personne de l'albino.
So this project is really evolving wonderfully. The third main topic is that of developmental disorders. And actually, developmental disorders is a term we use to indicate congenital anomalies. For instance, children with a heart defect or a cleft lip, and intellectual disability which was formerly called mental retardation. And actually, the whole center started with the PhD from Professor Emelu Maka. He was the first PhD student, and you heard him before. He's now really an expert, not only in clinical genetics, but also in molecular genetics. And he gained his PhD already in 2015 on a genetic etiological study of intellectual disability in the DR Congo. His research was followed up by Dr. Jerry Mubungu Dr. Mobungi is currently in Leuven because next Wednesday she will defend her PhD thesis on congenital malformations and minor anomalies in Congolese newborns. And I will give her the word now.
I am Jenny Mobungi. I am a pediatrician and medical geneticist. I work on congenital malformations and minor anomalies in Congolese newborn. Congenital anomalies are a major health problem worldwide. They are linked to the high mortality rates in the world, particularly in my country. In Central Africa, an estimated 1 in 7 children dies before the age of 5 years. For children with a congenital anomaly, life expectancy is even lower. The diagnosis and management of congenital malformation is suffering of lack of training of physicians or lack of equipment. And not everybody has access to appropriate care for congenital malformation because the cost is most of the time prohibitive and there is no reimbursement for cost of the treatment in Congo. In addition, the perception of the origin of congenital malformation is also particular because the mystical beliefs prevail. The general aim of the study was to perform research on the incidence and impact of congenital anomalies and dysmorphism in Congolese newborn. We established a network with 2 maternities located in Kinshasa where we conducted our study. We also work at the University Hospital. We determine common trait of our population. We define dysmorphism as the presence of 3 or more minor anomalies. However, we observe that newborn with dysmorphism and major anomalies constitute a significant risk of mortality. This highlights the importance to evaluate dysmorphism when child is admitted to the neonatal intensive care unit, but also in the maternities. Next, we establish a reference values of the facial features for term newborn. As described previously, there is a difference between Congolese and Caucasian facial features. Given the subjectivity of evaluation of facial features, we finally evaluated an automatic tool for the analysis of facial features. However, ethnic background influences the facial expression of common genetic syndromes. To optimize performance, histogene needs to take ethnicity into account. The data we obtained in the study will guide clinicians to better recognition of children with congenital malformations, as well as an improved care, leading to better survival of these children.
Okay, so based on this initial experience, we will now initiate another research project, and this will be done by Dr. Dali Chika, a PhD student, currently pediatrician, and she will actually, a bit in a similar way as we did for the persons with oculocutaneous albinism, study clinical and genetic aspects in people with Down syndrome in Central Africa. The team in Kinshasa really gained a lot of expertise, which was recognized by other teams in Africa. And this is how we got involved together with Johannesburg in a project, a research project, DDD Africa, or Deciphering Developmental Disorders, which was sponsored by the NIH from the United States of America. So the idea is to perform up-to-date genetic testing. So the most advanced genetic testing by exomes for the specialists among us, in 500 people with unexplained developmental disorder. And Dr. Prince Makai, he is actually the PhD student from Kinshasa mostly involved. So the partners in this project are Kinshasa and Johannesburg with support from Leuven, and then the Sanger Institute in Cambridge. And I will give the word to Dr. Prince Makai.
I begin to recruit patients from and and after that, they put the straight from our lab and our user was home to the Congo Institute via Leuven and University of Kinshasa. So the move follow my requirements in collect content from
et avec ce que nous faisons aujourd'hui, c'est pas de compétences. Ils peuvent faire certaines recherches, parce qu'à l'issue de leurs recherches, de leurs examens, nous pourrions avoir un développement de compétences sur l'handicap de nos enfants. En tout cas, c'est quelque chose qu'il faut encourager. Encourager, nous parents, nous encourageons. Mais il faudrait que même du point de vue de notre gouvernement, on encourage ces gens. Parce que les enfants avec handicap, on a d'autres il y en a ici à notre pays.
So as you can see, over the past 10 years, the Center for Human Genetics in Kinshasa really has gained a lot of expertise. And this is reflected by over 25 scientific papers in international peer-reviewed journals. And I'm confident that many more will follow. So in name of the Kinshasa team, I would like to thank you for your